I'm Scylla, and this is Lorenzo. We are doctors looking for a way to combine our passion for medicine with our love for exploration. We picked up our lives and sold all our stuff to start a new adventure.
Hit the like and subscribe, and let's go. Hey, this is Lo, just getting back from my shift at TTM Hospital. I'm here in Apia, Samoa, where I've been for the past 4 weeks, working with local emergency physicians, training point-of-care ultrasound, teaching them a little bit about my way of emergency medicine and learning a lot about their way of emergency medicine. And it's just been a wonderful experience. We've had some really great cases, and outside of the hospital, I've been soaking up all the culture and all the food and making some really great friends and connections. I'm super excited to share it with you. Let's go. All right, so I just got back from the hospital. Right outside the hospital, these bros every day sit outside with a table full of oranges. I was like, why not? Let's get a nice bag of oranges. So I'm gonna have a nice orange while I tell you about my day. I usually go in for like 4 to 6 hours, sometimes a full 8-hour shift, and sit with the emergency doctor that's on shift. There's usually one doctor, a whole host of nurses. It's about a 14-bed emergency department. There are only a few consultants, so you have general medicine, pediatrics, OBGYN, and general surgery, sometimes who is also an orthopedic surgeon. I mean, everybody's kind of plagued by, low resource challenges and kind of just working the best you can in that sort of environment. And if you could smell it. The doc that I was on today was really working on her cardiac ultrasound skills, and that's what we were working on with a guy with cardiogenic shock. This other person who was septic and hypotensive, a STEMI. So we were checking wall motion abnormalities, and this was all just in 6 hours. So pretty packed day. Yeah, days go pretty fast. We usually get a few cases that are good for point of care ultrasound. And so far we've run the gamut from cholecystitis to ruptured ectopic to appendicitis in a child, positive fast, negative fast, cardiogenic shock. We've done it all, and they've really absorbed everything like a sponge, and it's been just fabulous. And so now I get to enjoy my orange, which is good. One of the cases today we intubated. It was just a great, challenging hypoxic respiratory failure due to pneumonia, and starting with a saturation already in the 70s, and so that was kind of hairball, but it was interesting to see everybody kind of kick it into gear and get this guy the care he needed. All right, so I just have to interject here for a second. This case was crazy. This is the case that every ER doctor gets goosebumps about. So this person came into the hospital, low oxygen levels because the patient had an infection in the lungs. The infection in the lungs prevents the lungs from providing oxygen to the blood. This leads to hypoxic respiratory failure. This is when your oxygen level that you measure with your little pulse oximeter, that thing that goes on the finger, is too low. When it's too low, you're not getting enough oxygen to your brain, to the rest of your body, and things start shutting down. You become very tired, you become somnolent, you go into a coma, essentially. And so this is what was happening with this person. What I did was provide BiPAP, which is bi-level positive airway pressure, just to be able to push a little bit more air into the system and possibly avoid intubation, which is when you put a breathing tube in the trachea to ventilate the patient. So the BiPAP was going well for a little bit, and then suddenly the oxygen level plummeted even more, 95% oxygen level with the pulse oximeter, and then it went down to 70s, 60s. And I was like, all right, well, now our hand is forced. We have to place a breathing tube. We have to intubate the patient. So I go to intubate the patient. Basically, you prepare all your things. In emergency medicine, what you want to do is have everything ready to go so that when eventualities happen, like bad things that you anticipate are going to happen, you're not caught with your pants down, essentially. So we laid everything out. I asked for the medications. The nurse pushes the medications, and the two medications that we use for intubation are a paralytic agent and a sedative agent. So in this case, we use etomidate and rocuronium. Etomidate is a sedative. It causes amnesia, it causes you to forget, it causes you to sleep. Basically, it makes the unpleasant things that we do, like placing a breathing tube in your trachea, not in your memory. And then we need a paralytic. So if the person is breathing, moving around, the windpipe is moving, the vocal cords, which block your access to the trachea, are moving, it makes everything harder. So we like to paralyze the patient. Of course, we don't paralyze the patient without sedating them, because that would be pretty torturous. In this case, we had our sedative agent etomidate and our paralytic rocuronium ready to go. The nurse pushes them, and then I changed the knob on the oxygen coming out of the wall. We have oxygen supply that's plugged in through the wall in the hospital, and you place a little breathing tube attached to that, and that goes into the nose or to the BiPAP or to your bag valve mask, which is what you use to ventilate the patient when they're in a comatose state. And I realized that nothing is happening when I'm turning, and the paralytics are pushed, the sedatives are pushed, which means it's go time, we have to intubate. And I realized that the oxygen is actually broken at the wall. Nobody had realized this. It's kind of a horror dawning on me as things are happening. I see the oxygen level continue to go down because now the patient is sedated, he's paralyzed. The little amount of breathing that was happening is not happening anymore. And everything just happens really fast. You know, time sort of slows down in this situation. You have to place the breathing tube as quickly as you can and accurately as you can, so you don't mess that up and have to pull out and redo it again, because obviously you're already starting at a low level. So oxygen level creeps down, down, down. The heart rate response to hypoxemia is to also go down. You get bradycardia. And so I'm like, well, I am worried that this patient might have a cardiac arrest. So everything has to go very fast and smoothly. And fortunately, I was able to get the tube on the first try. The tube went in, and I immediately gave some breaths directly to the lung through the breathing tube. And slowly, the oxygen level came back up, the heart rate came back up, and we essentially avoided disaster. But that was definitely what we call a sphincter tightening situation, and it wasn't an ideal situation by any means, but things like that happen, especially in this sort of context. A lot of supplies are missing, a lot of supplies break, and so you have to know how to adapt on the fly and troubleshoot as you can, or kind of do the best with what you have. And so that was a hairball situation.